All right, we'll go ahead and get started. Hi, Rachel. Thanks for joining us.
There you go.
So the goal for today is we're going to talk about heart blocks. That's when the SAO node sends a signal, but it doesn't get through to the ventricles. So there's different types of heart blocks we'll talk about. We'll mention a 12-lead EKG. Not that you're supposed to interpret a 12-lead EKG, but respiratory therapists are required to run 12-lead EKGs using the machine. So we'll just talk about placement. We'll go through some electrolyte disturbances, and that's it. So when we finish lecture, we have lunch, and then we'll work on the VFib VTAC algorithm using Megacode Kelly in the back of the room. So I'll put you guys into groups, and each group should get through the algorithm twice today. So that's the goal after lunch. So the first block we talk about is called first degree AV block. AV refers to atrioventricular, meaning the conduction is not getting from the atrium into the ventricle. So with first degree block, the conduction does get through, it's just delayed. So the distinguishing features are a normal sinus rhythm with a prolonged PR interval. So we've been measuring PR intervals, and what is normal? How many little boxes is considered normal?
3 to 5.
Yeah, 3 to 5 little boxes. And then 5 little boxes is what, 0.02 seconds? Nope, I didn't do that.
0.004.
0.2 seconds. So 0.2 seconds is normal time for the conduction to get from the SA node to the AV node. But conduction through the AV node is delayed, so it's going to show a longer PR interval. And when you look at the PR interval, remember you begin as soon as the P wave leaves baseline to where the QRS begins. So can your eyes tell right away that that looks longer than normal? So that's just delayed conduction through the AV node, so it makes the PR interval longer. All right, the next block, it's a second degree block, but there's 2 types of second degree. There's type 1 and type 2. So with type 1 second degree block, it says each impulse has more and more difficulty passing through the AV node. The PR intervals become longer until an impulse is not conducted through the AV node. So there will be a missed beat altogether. There's another name for it. It's also called Wenckebach. So what causes second degree type 1? I'll tell you, and then I'll also write it in the chat. So a myocardial infarct will cause second degree type 1. AV node ischemia, especially if the right coronary artery becomes occluded. Drug toxicity can cause second degree type 1. And electrolyte imbalance, such as high potassium, can cause second degree type 1. All right, so that was the list. Let me put it in the chat.
Remember this and going on.
I like that.
The interval get more and more, and then stop and stop.
Going, gone. All right, so when you're writing in your notes, maybe you can make it a little bit neater, a little bit more organized to help you remember it. So one of the first causes is acute MI. So we have infarcted muscle tissue. This one is mentioning an infarct because of the right coronary artery occlusion that affects the AV node. So here in the chat, I wrote acute MI from AV node ischemia due to right coronary artery occlusion. So that's the first one. So I think better words would be right coronary artery occlusion causing AV node ischemia. That would make more sense now that I'm looking at it. The second one is drug toxicity, and drugs that can become toxic and cause second degree type 1 are digoxin, calcium channel blockers, and beta blockers. Okay, and then the third cause is electrolyte imbalance, specifically potassium. So having low potassium, you need potassium in order for conduction to occur normally. If the potassium is really low, you can have second degree type 1. You got all three of those written in? Okay. All right, so here's a picture, and when you're looking at the PR interval, right here, it is, looks like 6 boxes. So yeah, right away you think, oh, okay, we've got a really long PR interval. But then when you look here, you notice that it's even longer than the one before it. And then you look here and you see it's even longer than the one before that. Then you see a P wave and there's no QRS that follows. So what's happening is the AV node is becoming more and more refractory or unresponsive to conduction, to the point where it doesn't conduct at all. And then it resets itself and it starts responding again. So it starts over with a PR interval being a little long, then it gets even longer, and then it'll keep repeating itself. Long PR interval, and then a P, and it doesn't conduct at all. All right, so that was second degree type 1. Now there's another one, second degree type 2. It's failure of sinus impulses to be conducted through the AV node to the ventricles. And what you'll see is that you have more than one P wave before each QRS. So it could be P wave, and then a QRS. Or it could be P wave, and then a QRS. Or it could be P wave, and then a QRS. So that's where it's mentioning the conduction. So 2 to 1 conduction, what does that mean?
2 P waves.
Very good. 2 P waves to every 1 QRS. And if the patient is symptomatic, a pacemaker is indicated. I didn't give you my notes. All right, so for first degree AV block, what I should have told you is the patient is asymptomatic and nothing needs to be treated. So first degree AV block is considered a stable rhythm. You don't have to do it. Second degree type 1, it may resolve on its own. Or it may progress to more serious blocks. So it may resolve on its own, or it may progress to more serious blocks. So if I were to ask you, will a second degree type 1 considered a serious arrhythmia, like the patient's really unstable? And you said no, you would say no, but the patient needs to be observed because it could progress to something more serious. So observe patient because it could progress to something more serious. So that was second degree type 1. Second degree type 2 is considered a serious cardiac arrhythmia. So second degree type 2, you've got your 2-to-1 conduction, 3-to-1 conduction, etc. That's considered a serious arrhythmia because it may progress to complete heart block. And then as far as what is a pacemaker, oh, it doesn't give you any other information. So if the patient is symptomatic, it says a pacemaker is indicated, and we'll talk about a pacemaker. But what kind of symptoms would somebody have if they have an unstable heart rhythm? Altered mental status, chest pain, and cold clammy skin, period. So altered mental status, because you may not be getting enough blood flow to the brain, so they're not going to be alert and oriented. They may become lethargic. Chest pain, because of the heart not getting adequate perfusion of oxygenated blood. The cold clammy skin, because of the shocky type response of the body to a low cardiac output. So that's symptomatic. And what is a pacemaker? Oh, wait a second, I have a couple things here. That's a lot of notes for one slide. Well, you guys are typing or writing on separate paper? Okay. All right, so let's go with causes first, and then I'll write down some notes about a pacemaker. So causes of second degree type 2. The first one is left coronary artery occlusion. Second, degenerative changes in the conduction system. Drug toxicity again, and it's the same drugs. And again, electrolyte imbalance, such as low potassium. So it looks like second degree type 1 was from the right coronary artery getting occluded, and second degree type 2 is from the left coronary artery getting occluded. Everything else, as far as causes, they kind of all are the same. All right, so now for pacemaker. So a pacemaker can be external to the patient and just have wires going in through the usually subclavian vein, and it's threaded into the right atrium. So something like that would be temporary. So there's an external pacemaker with wires. The wires get threaded through the subclavian vein, and then the wires sit in the right atrium. And it'll send out an electrical signal, and that'll cause the heart to depolarize. Or the pacemaker can be implanted under the skin, and that's again permanent. And then the wires are threaded into the heart so they can stimulate the heart. So it can be an external pacemaker, or it can be an implanted pacemaker. And then it applies an electrical current to the heart, which initiates an impulse. So I wrote two things. I wrote the pacemaker can be external. The wires are threaded through the subclavian vein until the wires are located in the right atrium. And then the wires stimulate the heart muscle to depolarize. The internal pacemaker also has wires, but the pacemaker itself is implanted under the skin. And then I wrote the pacemaker applies an electrical current to the heart, which initiates an impulse. Does that help you to see it a little bit better? Okay, let's look for a picture. So when we're looking at this, we say, oh, look at the PR interval. That looks like it's 6 boxes. So then you say, oh, is this a first degree block? And then you see this, here's a P wave, there's no QRS. So we've got a P wave, another P wave, and then finally a QRS. So when you see P waves without a QRS, we're looking at a second degree heart block type 2. So this would be 2 P waves to 1 QRS. So we would call this a 2-to-1 conduction. All right, next.
Telling the two second degree blocks from one another, what would you say would be the defining difference between the vertical and
Yeah, so second degree type 1, it's that longer PR interval, just keeps getting longer and longer, and then there's a dropped beat.
to the variables for the ones that have the QRS?
Yes. Yeah, so when it does conduct through to the ventricle, that PR interval is always going to be the same. Yes, correct.
Same length, but can have more than one.
More than one what?
Like if there's another P wave, if there can be more than one P wave, but the lengths will still be the same.
Yes, perfect. Quinta, were you going to say something? Gretchen, were you going to say something?
Question. For the external one, it says the wires stimulate the heart muscle to polarize, and then for the internal one applies electrical current to heart, which initiates an impulse. Do those both mean the same thing, or they do different things?
Yes,
So we can just memorize one way to say it, not two different ways for each.
yes. Yeah, so to memorize, you would say, okay, a pacemaker will depolarize the heart muscle. And the pacemaker can either be internal underneath the skin, or it can be external.
Thank you.
Mhm. So do we need a pacemaker for first degree heart block? Do we need a pacemaker for second degree type 1? Possibly. Especially if it progresses to something like second degree type 2 or complete heart block. All right, so if you can remember pacemaker for second degree type 2 for sure. And for complete heart block, which is what we're going to talk about now. So with complete heart block, there's no conduction between the atria and the ventricles. And it's due to damaged heart muscle or heart tissue. So the SA node will initiate an impulse. It'll spread through the atria, and that's it. The ventricles are not getting an impulse, so they're going to say, hey, wait a minute, I'm not getting any impulses from the AV node. I'm going to start my own impulses. So then the ventricles will start initiating pulses, conduction. But of course, it's going to be slow. Remember how slow it is for the ventricles to initiate an impulse, like 20 to 40 times a minute. So you'll see a wide QRS, that's slow. You'll also have P waves, but there's just no correlation between them. So what do we have here? Complete absence of conduction between the atria and ventricles. Atrial rate will be regular, and the ventricular rate will be regular. But when you're looking at it on a piece of paper, what it's going to look like is that your PR intervals are going to be crazy. They're going to look like the PR intervals are all over the place, but they're not. They're just P waves are on the paper, and then the QRSs are on the paper. It's just how they land. It looks like you have varying PR intervals. So here we've got complete heart block. So there's a P wave. P wave, P wave. So if you take a piece of paper and you mark the paper for these two P waves and you move it across the strip, you'll notice that all the P waves are the same distance apart. So all the P waves will be equal distance from each other. And then the QRSs, you're going to have a really slow ventricular response, so about 20 to 40 per minute. So when you put them together on the paper, doesn't it look like you have a crazy PR interval? Here it looks really long. This one looks long. This one looks shorter. This one looks short. So PR intervals are not making sense. So if the PR intervals don't make sense, erase that from your mind and think, P waves are regular with each other. QRSs are regular with each other, and they're really slow. You're going to come to the conclusion that you're looking at complete heart block.
At a glance, you might think that this type, second degree type movement. But the rate is what should tip you off, but this is something else.
Mm-hmm.
It's gonna be a slow rate, it's gonna be a bradycardic rate,
It's gonna be between 20 and 30.
Yes,
and then that we gotta measure both the QRS and the.
very good. Tiffany?
Let's talk.
Dead tissue.
So why did you put in the basement?
Oh, that's a good question. Why does the pacemaker get through that dead muscle tissue?
Does it have a stronger like electrical like current to through into tissue?
I would imagine. So we'll have to ask a cardiologist that question. Yeah, if you come across a cardiologist in your clinicals, you know, if they're stepping in to see a patient and you know they're the cardiologist, you can ask them. I'll try and do the same. So why is it that the pacemaker can conduct through this tissue, stimulate the AV node, but the heart's electrical system can't? All right, so that's it for heart blocks. First degree, second degree, there's two types, and then complete heart block. All right, so let's see if we can look at a strip and figure out what we're looking at. So take a look at the top. We have a rate of 50 per minute. We see a P wave. The PR interval is really long here. Here's a P wave with nothing. Here's a PR interval that looks normal, 5 boxes. This PR interval is a little bit longer. This one's really long. All right, so what I'm noticing is the PR interval keeps getting longer and longer. And then here's a P wave and no QRS after it. So what's the name of the heart block where the PR interval keeps getting longer and longer and then it's dropped?
Second, type 1.
Very good. Second degree, type 1. All right, look at the one at the bottom. Can you find the P waves? They almost look like the ocean on a really calm day. It's not super obvious, but they're there. This one is an obvious P wave. This is a P wave. Here's a P wave. So there is a P wave before each QRS. But what about the PR interval? You see how long it is? So it's a prolonged PR interval. And they're all the same. It's not like the one above it where they keep getting longer and longer. They're all the same. So what is the name of the heart block where you have a long PR interval? Very good. First degree heart block. All right, so here we have slow rate, got a P wave, another P wave, P wave, P wave. So we have some P waves that are followed by a QRS, and then we have some P waves that don't have a QRS. Very good. So we're looking at second degree type 2. And then the next thing we would do is we would mention the conduction, like how many P waves before you actually get a QRS. Two, very good. So there's 2 P waves and then a QRS. So you would call this 2-to-1 conduction. So second degree type 2 with 2-to-1 conduction. Oh yeah,
But that's how we're gonna have to answer them with like the 2-to-1, 3-to-1. 4-to-1.
yes.
Is that only for type 2? Yeah.
Mhm.
That's 2 P waves?
This is a T wave. Is this the one you're referring to? Yeah, you always have a T wave. So you find that first and then you know that it's not. You have to go.
No,
All right, so what is at the bottom? It's a slow rate. It looks like it's 50. Very good. And how do you know that?
Did he say 30?
The wide QRS. So we know that the ventricles are initiating their own impulses because they're wide.
But wouldn't it be under 40?
Yeah, that's what I'm thinking too.
So, like, yeah, if we got a test question like that, and originally, like, we know it's supposed to be 20 to 40, but that's 50, but it looks like, so it still would be third degree, or?
Yeah. Yeah. And do you see any PR intervals? They look like they're all over the place, don't they? So when you see a PR interval, here it's long, here it's short, here it's really long, in between. When you see weird PR intervals, that's a clue that there's no communication between the atria and the ventricles.
I just wanted to note, sometimes if you don't, do the measurements, the measuring the Q waves, sometimes the QRS will hide the Q wave.
Perfect. Yes, that's
So
true.
doing a measurement, don't think that there isn't one there. All the others are, evenly split, that just the QRS.
Yes, thank you for that.
And another indicator could be because it's going from the bottom, like the QRS is going from the bottom up instead, which is showing starting from the ventricles instead of the atrium. It's like the way, that's the word for it.
Yeah, instead of an upward deflection, it's a downward deflection. Are they always down? It feels like they are.
Yeah, because I'm confused, because if it starts from the ventricles, wouldn't it always be a downward deflection?
So downward deflections can happen when you have your positive lead away from the left ventricle. So if you have a positive lead over on the right side of the body, you're going to get a downward deflection.
Okay. I thought it
So
was
you can't say all downward deflections are complete heart block.
No, I know. I was just saying it's like a helpful indicator, like sometimes, but is that true? Like if the ventricles are going, starts with the ventricles, will it be a downward deflection also, or was I just?
So I'm not going to answer that question yet.
Okay.
I'll pay attention because I'm feeling like they're always down, but I'm not sure. So I don't want to answer that question. All right. So you're looking at this, you're seeing a slow ventricular rate, seeing a wide QRS. PR intervals look like they're all over the place. So what you'll do is you'll measure the P waves and see if they're all the same distance from each other. And that tells you that the P waves are sending out conduction in a rhythmic form, I guess. And then the ventricles are all the same space apart. So they're doing their thing. And then you come to the conclusion that you're looking at complete heart block. Okay, here's some more examples. What is at the top of the page?
So it's second degree to 2.
That's a crazy looking T wave, isn't it? So if that's a T wave, and that's a T wave, it's not a P wave. So there's only one P wave only one P wave before each QRS. Very good. Second degree type 1. No, I mean, first degree heart block. I'm sorry. That one's confusing because this looks like a P wave.
Yeah.
If that's a P wave, where's the T wave?
The one below it looks like it doesn't seem to have, there's that one.
The one below it?
Yeah.
The strip on the bottom? Okay, so let's look at the strip on the bottom. Tell me what you think.
Because the rate's so slow, and there's a P wave without a QRS.
Okay, very good. So you're seeing a slow ventricular rate, and it's wide, and you're seeing a bunch of P waves. So you'll notice that the PR intervals aren't making sense, and that's because there's no communication between the atria and the ventricles. And you come to the conclusion that you're looking at complete heart block. Any questions? Let's see. I want to show you something before we go forward. You can practice this is funny. Some students got together and did a dance to, I think, like a Justin Timberlake song. So that's fun to watch. When you go here, and you go on to skill stat, it'll throw up a bunch of rhythms and you have to guess what the rhythm is. So that's the game. If you're just learning, it has 27 of the most common cardiac rhythms. Have we learned 27 already?
Jesus. I don't think we learned that.
Well, let's see. Sinus rhythm, yes. Sinus bradycardia, sinus tachycardia. These three, no. I kind of mentioned them a little bit, but not too much. Okay, normal sinus rhythm with a PAC. Did I mention premature contractions? All right, what about SVT? Yeah, atrial fib, atrial flutter, paced atrial. We're going to talk about that now. Anytime there's a pacemaker, you'll see a straight line in front of the P wave or a straight line in front of the QRS. That's how you know it's a pacemaker. First degree block.
Yeah.
Second degree type 1. Second degree heart block type 2. Second degree with 2-to-1 conduction.
That's just the same one, but categorizing.
Yeah. What about complete heart block? Third degree AV block. Okay. Premature junctional contraction, not a PVC. It's probably a PVC. So you know what a PVC looks like. What about a junctional rhythm?
Yes.
Okay, accelerated junctional
Yes.
and junctional tachycardia.
Yes.
A wandering pacemaker where all the P waves look different from each other.
Yes, we did.
I mentioned it. I said it wasn't on the exam. Normal sinus rhythm with PVC, that looks the same. Idioventricular,
Yes.
accelerated idioventricular. VTAC,
Yeah, we have.
VFib, a paced ventricular rhythm. Well, we're getting to it. All right, so let's play the game. Does it tell us how long we have? 1 minute. So everything looks normal, and then once in a while, there's one that's a little bit quicker. So this isn't one that we went through. Let's reset it. Oh, so if you hit stop, it doesn't freeze it. I wanted to freeze it just so we could look at it a little bit easier.
This is so hard to do.
this a lot when I was,
Like you have to know this down pat to look at that quick and be like, oh.
will you use this, or something like this on the test?
What's something moving?
I wish there was a way to pause it. What about this one? How do you know? Very good.
Right.
Ooh, what's that?
No P wave.
No P wave.
Starting at the ventricle.
Mhm. So the AV node is initiating the impulses. Very good. Junctional rhythm.
The moving's not doing it for me.
I know. This one we don't. Because you've got, once in a while, you've got impulses not being conducted. We didn't talk about that one.
I know this one.
Guess again. VTAC, very good. Where is it? Oh.
Right.
Oh, looks like a saw. Looks like the serrated edge of a knife.
Right.
Looks like regular. Yeah.
Okay,
Right.
very good.
Oh, that's the block, that's the hard block.
Heart block wouldn't be that fast.
Uh,
We, bundle branch block, that's what you're thinking of?
Yes.
Okay, is that one of the options? Maybe junctional tachycardia or SVT? SVT?
Oh, it is, yeah.
I don't know if it was. It
Yeah.
was SVT or junctional.
The QRS, complex, you see the way that it's like separated?
So there was a bundle branch block?
Yeah, that's what I
or-
was thinking.
Yeah, but that wasn't one of the possible things, right?
This is on D2L though.
Bundle branch block. Yeah, it's in D2L under tools. Yeah, I don't see bundle branch block anywhere.
Yeah, it's learning instead of the game.
Oh, yeah, VFib. Tells you about the rhythm. VTAC tells you. Yeah, I agree. Look, and there's no commercials that come on and it's free. You don't get that very often anymore.
But like for these, I'm assuming you probably don't know this in turn, but like, is there only one example of each of them? Probably. Okay, because obviously sometimes they're always gonna look a little bit different. So if you get so used to looking at that and then you're like, oh, wait,
Yeah, it's true.
but it can help, yeah.
Have we seen the sinus exit block yet?
Let's see.
No, we haven't.
So sinus exit block, sinus arrest, they look the same. You just get this big long pause. Oh, look, it stops.
Also when it's in words.
It doesn't work when you're playing the game. Oh, this is a good one to look at. What do you think? Lots of P's, wide QRS that's really slow.
PVC,
No.
Third degree.
Well, with the slow ventricular rate and the QRS is really wide, it's complete heart block. Yes. And by the time I find it, the time will be up. Third degree heart.
Right.
Yeah, so play with that so that you're ready for your exam next week. Because your exam has got all your possible rhythms on it. Yes. And it just takes practice. It just takes looking at them over and over again and you get really good at it. So. We'll take a 10-minute break and then we'll talk about pacemaker rhythms. 13 to 30. Oh, we do have like half of it left.
I have like a bunch of ones. They were free from the time. It was like, yeah. They were giving them out free and I was like, well, I'll take a bunch. Weird.
Yeah, it looks really good. Yeah, it's okay. Thank you.
I don't know what it is. I know that one was due to that.
Any rapid response? Stop the recording. All right, we'll keep going. All right, we'll talk about pacemaker rhythms. It says pacemakers can be temporary, and then we already talked about having wires threaded through the subclavian vein. And then the pacemaking device will tell, or give the signal to the heart to depolarize. Permanent pacemakers are implanted under the skin. Then there's atrial pacemakers that stimulate just the atria, because there's nothing wrong with the AV node sending the impulse down to the ventricles. So we don't need a pacemaker to do that. We just need it for the atria. So that would be called atrial pacing. And ventricular pacing is when ventricles are not getting an impulse and we only need to stimulate the ventricles. So that's ventricular pacing. And then when the pacemaker sends out an electrical stimulus, what shows up on the EKG is a solid white line. And then I'll show you AV sequential pacing. That's when you have both atrial and ventricular pacing. So here, this is showing the ventricles being depolarized by the pacemaker. So the pacemaker spike is a solid line. Did I say it was white earlier? It's not. So there's just a little line, and then you'll notice that the ventricles have a wider QRS because of it. So when it's a pacemaker depolarizing the ventricles, you get a wide QRS. So here's a straight line right before you see a P wave. So that's the pacemaker depolarizing the atria. The second one, you see a pacemaker spike right before the ventricles depolarize. That's ventricular pacing. And then you can see both, one before the atria, one before the ventricles. So they put that fancy word in, sequential, AV sequential pacing. Where was it mentioned? Oh, right here. So AV sequential pacing. The pacemaker depolarizes the atrium, and then the pacemaker depolarizes the ventricles. All right, so that's it for pacemakers. Oh, there's a question in my notes. What is failure to capture? Let me write that question in. Failure to capture. Yeah, so the pacemaker is supposed to stimulate the heart muscle, and when it sends out the conduction, nothing happens. So it's like the failure to capture, pacemaker is not stimulating the heart to depolarize. Next thing we talk about is electrolyte disturbances. So having abnormal amounts of potassium, calcium, magnesium in the body, it'll create changes in the EKG, and you'll be able to look at an EKG and tell if a patient has high calcium, low calcium, high potassium, low potassium. So hyperkalemia is referring to high potassium. So high K. So high potassium. And you get peaked narrow T waves. So high potassium, you get high T waves. As I spit and give my audience all wet. Every year I do this, and every year everybody gets it right on the test. So that's why I go ahead and I make a fool out of myself. People who have graduated and they say, oh yeah, I remember the peaked T waves for high potassium. So you'll see me 3 years from now and you'll remember that. So high potassium peaked T waves. With low potassium, the ST segment is low, and then you get another wave. So it's like you have two T waves, but they don't call it two T waves. They call it a U wave. All right, so let's look at some examples. Do you see these peaked T waves? What's wrong? High potassium. Here we've got a T wave and then another wave. So the ST segment is low, and then we have two waves. So a T wave and a U wave.
How can you tell that it's not two T waves?
It could be confusing.
Okay.
Definitely. So it says the T wave. Go ahead, Tiff. Yes. Okay, and then extremely low potassium, the U wave becomes more prominent. I feel like we looked at this. I don't know if it was a strip at Broward or.
But if the ST segment isn't like on your isoelectric line, isn't that indicative of a? So then how do you know it's low potassium versus another?
With an MI and having a depressed ST segment, you don't have a U wave. So I guess it's the combination of a couple things that tells you that it's low potassium. Yeah. And here it almost looks like the T wave is inverted. So as far as identifying it on an EKG, it is not an exam question as far as identifying it. But do you have to know what changes there are with high potassium and low potassium? Yes. You don't have to identify it, but you have to know that. Because it takes time to be able to identify these things on an EKG. All right, the next one is high calcium and low calcium. So having a lot of calcium, the QT interval is shorter than normal. I don't know, here it looks regular, but I don't know how to make this memorable. High calcium, short QT. High cutie. Would that be good? And then if you notice, it takes a long time for the ventricles to repolarize. You have a long QT interval, and that's because of low calcium in the body. All right, so that was it for electrolytes. High potassium, low potassium, high calcium, low calcium.
Question.
Yes.
What is the U wave? Because I'm looking for it here. I don't see anything about it.
You don't see anything where?
About the U wave.
In the textbook?
No,
Or
no, no, right here. I see U wave, but I don't know what is it.
okay, let me go back. So this is supposedly an inverted T wave.
Mhm.
And then there's another wave that follows. So another wave is called the U wave. So if you've got your T wave and then another wave, they label that U wave.
So it's not a P,
It's not a wave?
a P wave.
No. No, a U wave is not a P wave. You can see the P wave for this EKG is here.
Mhm.
So that's what the P wave looks like. So look, the U wave looks different than a P wave, than this P wave.
So the U wave is involved in depolarization along with the T wave, right?
Okay.
Yes,
Makes sense. Okay.
that makes sense. Good. Okay, that was the missing part.
Yeah.
All right, so doing a 12 lead EKG, we're just going to talk about the leads, where you place them on the body. We'll mention a couple things that the physician will look at to diagnose an MI. But I think it's just one slide. It's just like one slide that you have to memorize for the test, and then you can forget it. But running the 12 lead, why is it called 12 lead? There's only 10 leads. You put a lead on the wrists, one lead each on the wrists, leads on the ankles, and then 6 leads on the chest. So 6 plus 4 is 10, but yet it's called a 12 lead EKG. And the reason it's called a 12 lead EKG is because the machine will use all the 10 leads to come up with 12 different ways to view the heart. So it's 12 different views of the heart, but we only need 10 leads in order to get these 12 different views. When we put the leads on the wrists and on the ankles, they're called limb leads. And when we put the leads on the chest, they're called chest leads. So here's a graphic representation of where you would put the electrodes to get your 12 lead EKG. So when you place it on the right wrist, it's called right arm. I know. Left arm. The one that goes on the right, here it shows it on the knee, but it's typically on the ankle. And the right foot is called the ground. And then the left foot is LL for left lead, or left leg, I'm sorry.
Because I did an EKG and they put the left leg and the right leg on the top. And then they put the 6 leads below. So what difference?
Reading in the textbook, it does mention that the view is going to be different depending on how far away the lead is. Did it say how it's supposed to look different? No. And it shows the thigh?
Yeah, it showed the thigh.
Wow.
And then the 6 leads, they were.
Oh, interesting. And now there's 18 lead and 20 lead EKGs also.
I was taught that ideally the limb lead should be as distal as possible, and then that's connection. That connection, placement of the six is quite important, because you're looking at the conduction through different, angles of the heart. So, I see people, like, from all over the place, and the EKG does look different, if you don't put it right. But that being said, I'm also, if somebody's in a seating position, if somebody walks in with heart or chest pain, we'll do a rapid EKG, and they'll be sitting in a chair, which is not ideal, with their phone, most of it goes on. And I'll just put the bottom leads at the corners, like at their hips.
Oh, really?
I'm just trying to get an idea that I'm looking for an ST elevation. We'll do another one later on when they're laying down, but we just want to see right away if they have some ST elevation with these leads. And if so, then we can start moving faster.
So when they're in the chair, putting it on the ankle, that's not going to work, I guess.
I mean, it depends on what they're wearing. Sometimes I'll try to put it, wearing some new people like that. And I also want to use on the volume of confidence. Put it on a hoodie, maybe on the belt.
Oh, okay.
Away from the phone. So we usually go like inside the calves for the lower limb leads.
Oh.
Something needy.
Avoid the bones. All right, so when you're placing, the limb leads will send information to the EKG machine. Pardon me. You'll be able to get lead 1, lead 2, and lead 3 from the limb leads. You're also going to get AVR, which, what does that stand for? So the little a stands for augmented. Let's see if I can move this out of my way. So augmented, it says waveforms are small. So they are enhanced or augmented. So augmented means to increase in size. So the augmented V lead on the right, it will view the base of the heart. So this is, can I write in here? This is right arm, this is left arm, and then this is the left foot. It's easier if you guys just add it to your notes. So AVR is the lead that's on the right arm, and it's viewing the base of the heart. Remember, the base of the heart is the top of the heart. It's where your major vessels come out. So that's the base of the heart. So the V lead is sending in an electrical signal, and it can tell, and it can show a picture of the base of the heart. AVL, you can write in your notes. That's the lead that's on the left arm. It's viewing the lateral wall of the left ventricle. So having it on the right arm, whether it's on the right shoulder, the wrist, it's viewing the lateral side of the left ventricle. That's AVL. And then AVF is on the left foot. So can you add that to your notes? AVF is left foot. And that's looking at the bottom of the heart, or the inferior part of the heart. All right, you got that written in? And then here's a picture of what we were just talking about. So augmented V lead, right arm, it shows the lead. Here it's showing it on the wrist. And it's viewing, this is the base of the heart. When you look at the QRS, it's going to have a downward deflection, and that's because the heart's depolarizing away from the right side of the body. So any positive lead on the right side, you're going to get this downward deflection. And then for AVL, augmented V lead left arm, that's viewing the lateral wall of the left ventricle. It's going to have an upward deflection because the heart depolarizes toward the left. So it shows an upward deflection on the EKG. And then the augmented V lead on the left foot is viewing the bottom or the inferior wall of the heart. Heart depolarizes towards it, so you see an upward deflection. The next thing you do is you put leads on the chest. So chest leads, precordial leads, it means the same thing. The leads are unipolar. It's just a positive electrode, and a reference point is calculated by the EKG machine. So it's not like it's going between two different electrodes in order to get a waveform. It's just one. It sends a signal in, and from that, it can give you a view of the heart. The chest leads look at the heart on a horizontal plane. So when you're placing the chest leads, they kind of wrap around the heart because they're looking at the different views of the heart. Chest leads are labeled V1 through V6. So V2, V3, V4, V5, and V6. So V1 goes on the right side of the sternum. We have another PowerPoint, another slide coming up where it talks you through the placement. The placement is really important when you're doing the 12 lead. It's also on your exam next week. So we'll go through it in detail. But one lead is actually to the right of the sternum. The other one is across from the first lead. And then the rest of them just wrap around the heart. With V1 having a downward deflection, V2 having a downward deflection, it's because the heart is depolarizing away from those two leads. And then everything else has got an upward deflection. All right, so here's the placement. So placement of the leads, V1 goes on the right side. It goes in the fourth intercostal space. And then the question asks, how do you find the fourth intercostal space? And the answer to that question is you use the angle of Lewis. It's the bony protrusion between the two parts of the sternum. What is it? The body? What is the top part called?
Excellent. No, that's the bottom.
Manubrium, body, and xiphoid, right?
Yeah.
So between the manubrium and the body of the sternum, the bone sticks out, and that tells you where the second rib is. So if you feel over to the right side, you're going to feel a rib right there, and that's your second rib. Then below that is the second intercostal space, and then your third rib, below that intercostal space, and then your fourth rib. And that's where you would put your first lead for the chest, is on the fourth intercostal space. Then you're going to put a lead directly across from that on the left side. So that's going to be lead or V2. That's where V2 goes. Chris?
I'm gonna be looking for this understanding test questions.
Yes.
Like this particular placement.
Mhm. All right, so notice that it doesn't go in order. So I gave you V1, told you where to put that. I gave you V2, told you where to put that, and then it skips one. And when you're placing your electrodes, you want to make sure that V4 is at the 5th intercostal space, mid-clavicular line. So mid-clavicular line, 5th rib is exactly where you need to be placing V4. V3 gets placed afterward because it's going to go between V2 and V4. So when guys are doing a 12-lead EKG on a female, you have to be really careful how you place the lead. You don't want to get accused of anything. So of course you'll have gloves on. You're going to use your hand, and you're going to move breast tissue away with the back of your hand and to place your V4. So yeah, just be careful that you don't get into trouble with that.
I also explain what I'm going to do before I do it. I do this all, a lot.
Oh, okay.
To a lot of women as well.
Yeah, so share with us what your experiences are.
I've never seen more boobs than I have in this job. Yeah, somebody told me I was gonna be batting around with their 98-year-old boobs at some point. I would have been like, no way.
And here you are.
So, yes, the first time I ever did it, I was at an EMT training with the city of Miami. And we went to this house and we had to do an EKG in someone's house, and this giant woman. And I made a mistake. I had to move breast tissue. And I palmed it. That's the way. The guys didn't say anything until we got back to the truck. Like, yeah, man, you don't do it that way. So, yeah, you move it the back of the hand. But explaining what I did. Have you ever had an EKG done before?
A
Okay.
12 lead,
But,
you'd
yeah,
say.
Have you ever had one of these done before? A lot of people have. They haven't. Explain where, if I explain where they have to go, and are you comfortable with me doing this?
Wow, that's a good idea.
There's also cultural, situations you might be in. If somebody's in a burqa or something like that, you probably, as a man, you're probably not going to go and do that EKG.
Oh, I see.
So, but generally, older women don't care. They'll just pull them out. But for younger women or anything like that, I generally try to run it by them. 9 times out of 10, let's see, go ahead. You're gonna want to take any kind of bra off that has an underwire. But don't just walk in there and assume that they know what you're gonna do and everything and start, pulling the gown off. I also, there's ways to move the gown around where you don't have to actually expose the breast. So I do that too. And if they have a gown on, I'll scoot that down like this, so I can put the first 2 leads on. And then I'll come around from the side, push the gown over, kind of, so the gown's still covering the breast.
Oh,
And then
okay.
Put the leads on like that, so I don't actually have to expose everything. There's still gonna be some air contact, but it gives them a little bit more privacy to this.
Oh, that's great. All right. Can I, maybe after class, can I record you saying exactly what you said so I can show it in future years?
Yeah. I can even demonstrate. I mean, if somebody's willing, I can demonstrate it. You don't have a gown on here, do you?
Yeah, but I'm pretty sure nobody wants to be a model.
I mean, you could be like
I'm dedicated, Chris, but not that dedicated.
simulate on a guy too. I mean, just move the clothes around. It's something. It's good to know how to do.
So we'll use the mannequin. How's that? Okay. All right, so once you have V4 placed, the next lead that you place is V6. And again, it's the same thing. You want V6 to be at the 5th intercostal space, mid-axillary line. So that one's got to be put exactly in that spot. And then of course, V5 just goes between 4 and 6. So do you see how you don't just go in order, which I'm sure at the hospital, you're not going to see what I'm telling you. You're going to see everything. So I'm just telling you the correct way, the textbook way. In order to get a good picture of the heart, it's best to have the leads wrapped around the heart so that your waves look good. So V1 shows different parts of the waves. This is not a test question. V2 and 3 is looking at anterior wall, 4 through 6 is looking at the lateral wall. And this is what you get when you print your 12 lead EKG. So from your limb leads on your arms and feet, you get lead 1, lead 2, lead 3. You get AVR, AVL, and AVF. So those 6 views are coming from your limb leads. Then from your chest leads, you get V1 through V6. And they look different because they're just looking at the heart from different views.
It makes a lot more sense now.
Once you see it on a piece of paper. Oh, when you were at the hospital and you look at it?
I have some of these too.
Oh, okay. So now you know what you're looking at. So when looking for whether the patient is having an infarction, there are changes that occur in the different leads. So you can see ST segment changes, and I think it's coming up on a slide, so I don't want to start quoting the wrong things. So ischemia shows up as, oh, it's not going to tell us. It tells us to go to page 580 or page 483 to 489 to answer the following question. What EKG changes are noted on a 12-lead EKG that indicate infarcted tissue? So you would see T-wave inversion. You would see an elevated ST segment. And you would see large Q wave. So the answer is all of the above. But the textbook goes into more detail than that. Right, first it shows normal ST segment at baseline, and this just showing you your elevated ST segment. So just being elevated by 1 millimeter from baseline is enough to show ST segment elevation. This one's really elevated. What is that, like 3 boxes, 3 millimeters? Here you see inverted T waves. So an inverted T wave indicates myocardial ischemia. Oh, that's all we've got? Thought I had a picture of chest.
That was fast.
Yeah, that was fast. All right, so I'll just pull it up on our good old ImageMate. No, I don't have enough to pass out, so I'll just show you a picture. So I don't know how I did this on the exam. Because with a multiple choice, there's no way for you to indicate where these leads would go. I'll look it up during lunch break and I'll let you know. But in the meantime, tell me where V1 would be placed.
Right of sternum.
On the right.
Right
Okay,
side.
so on the right side. So here's my second rib. Do I put it here?
No, fourth intercostal space.
Oh. All right, so that's where V1 goes. Where does V2 go? Cross. Okay, and then what do I do next? V4, mid-clavicular,
And fifth
and
intercostal.
fifth intercostal space. So middle of the clavicle, fifth intercostal space, V4. And then 3 goes in between. Okay, then what do I do? Right, number 6 is next. Where does that go? Middle of the armpit, so mid-axillary. Fifth intercostal space. So I follow 5 around to the armpit. V6. And then V5 is in between. All right, so that's proper placement, and like I say, you see all kinds of stuff. But that's supposedly the way to get the best picture. All right, so when you come back from lunch, we'll get started on. Oh, insurance. Did you get your picture?
Yes.
I'll also look up to see if you have to say where the leads go, like where does AVR go, where does AVL go? And AVL. All right, so when you come back from lunch, we'll go through how you're supposed to get through your team, like each person in the team has an assignment. So either you're the one who's going to be doing the compressions, or you're the one who's going to be defibrillating, one person intubates. So I'll give you all those assignments and we'll go through the scenario first, really slow to explain everything. And then we'll start switching around. Okay? Oh, you gotta do it all. So the first time around you do compressions, the second time around you have to do something.
So back here at 12:30.
Yes.
Okay.